का ही होता है। हेलो हेलो। ठीक। हेलो 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 हेलो। माइक चेक। A very warm good afternoon to all of you. On behalf of Dr. Krishna Rao, the Senior Director of Maheshwara Medical College and Hospital, Principal, all heads of the departments, PG residents, interns, and dear students. I would like to welcome amongst us Dr. Rajendra Kumar, who's an MD in Internal Medicine from the All India Institute of Medical Sciences, New Delhi, and currently also the Principal Commissioner of Income Tax to our midst, along with our respected speaker who's always been with us for the last few months. Welcome to you, sirs. Just to put things in perspective, since it's Dr. Rajendra Kumar's first visit to this site, and to give a brief glimpse of where we are currently, ours is a 1200 bedded tertiary care teaching hospital, with 150 undergraduate students and 55 postgraduate residents joining us every year. We have the state-of-the-art infrastructure providing high quality tertiary patient care, and we have fully equipped intensive care units with self-sufficient oxygen generation plants. We also have NABL accredited labs and BSL-2 molecular virology centers as well. So no wonder our college is at a very higher standing than the other healthcare institutions in this part of the state. This is what the senior director had just alluded to you a short while ago. We've been consciously reaching out to the community and the clientele at large, at least about 4 to 5 times every month, so that we provide medical care at their doorstep, and they're aware that which month, which week, where we would be heading. And not just that, apart from the routine academic activities that we undertake for the undergraduates and postgraduates, we are the first institute probably in the state to be stepping out of the textbooks and getting a full code medical interactive software for the undergraduates and postgraduates. Besides that, we've been also looking at the environment as in general, and we care for the flora and fauna of this area. No wonder we have a very verdant green landscape all along and inside the campus as well. To set the ball rolling to today's continuing knowledge series, the fourth in its part in this year alone, wherein we'd be having an insight into being an intern, a professional conduct and clinical approach to patients with systemic illness. I would like to now invite upon stage our senior director to the dais, who is an accomplished academician and a physicist with about 33 years of experience in handling students and healthcare establishments. He's got multiple papers to his credit, and he's also the Vice President of the Telemedicine Society of India. And to join him on stage, our guest of honor today, I would also like to invite Dr. Rajendra Kumar, IAS Principal Commissioner, Income Tax, retired. We would also like to invite Sri Chakrapani sir, IAS retired, to our midst and welcome him to the dais as well. Thank you, sir. And to give you a brief insight as to what's in store for us, today we have amongst us, firstly, Dr. Rajendra Kumar, IS, the Principal Commissioner of Income Tax, who has been schooled at Barauni in Bihar. He's been a CBSE topper and an NTSE scholar, and he's been topper in his 12th standard. It's only natural that he chose his academic career and joined the All India Institute of Medical Sciences 1983 batch. Just to step out a little bit, any guesses how many seats were there at that time? How many seats were there in the AIMS at that time as an undergraduate? One more guess, sir. There were just 35. So he is one among that 35 who joined the college, and he went on to follow it up with an MD in internal medicine, the subject of his choice. In 1990 till 1995 he worked as a senior resident. He's done his dissertation on epidemiology of lung cancer, which was a case control study. No wonder he's got multiple publications to discredit in international journals. And he's worked under eminent physicians, Dr. Pandey, Dr. Vinod Kumar, Dr. Ahuja, Dr. Wazir, Dr. Tandon, you name it, name the who's who of AIMS, he's worked with them. And a few weeks back, or rather 2 weeks back, we had Dr. Jhandalia Shankar, who was the ex-mayor of Vijayawada. And just like him, I think Dr. Rajendra Kumar also had a new calling which he had passionately followed since his childhood. That was the civil services. And he cracked the exam, and he joined the 1995 batch. And not just that, as a part of his social responsibility, besides handling the income tax part, every Saturday for the last 30 years, he's been rendering free patient care services in the medical colleges and government hospitals. In addition to that, he's also been a visiting faculty to the Department of Medicine in teaching students on the clinical experiences, whether it be the college in Goa, Mysore, New Bombay, or even in Hyderabad as the commissioner. He did follow the same with vigorous passion. And the other colleges which he did visit were AIMS in Bhubaneswar, the Amrita Hospital in Cochin, Gayatri, Geetam, and the NRA Institute in Vizag. And of course, his visit to his old alma mater is pending, which I'm sure he'll be told will be undertaking shortly. He unwinds and enjoys his music. He's an avid traveler as well as sportsman, and he unwinds by writing poetry, blogging, and reading as well. We also have on the dais Sri Chakrapani sir, IAS retired, who's joined the 1983 batch. He's been the director for the Center of Innovations and Public Systems in Hyderabad, and he's worked in numerous various important assignments like the Additional Director General of the HRD Institute. He's been the personal secretary to the Pay Revision Commissioner, and has been the managing director of the AP Health, Medical, Housing and Infrastructure. It's no wonder that he has attended numerous fora abroad in Washington, in Malina, Thailand, Singapore and Australia. Welcome, sirs. And I'd like to request you all to please rise for the national song.
Vande Mataram, Vande Mataram, Srujalam Sufalam, Malayaj Sheetalam, Sasya Shamalam Mataram, Vande Mataram, Shubrajoshna Pulakitayamini, Pullakusumita Drumadala Shobhini, Suhasini, Sumadhura Bhashini, Sukadam Varadam Mataram, Vande
I would like to request Senior Director to felicitate Dr. Rajendra Kumar, please. I would like to request Professor Mova Gopal sir, Head of the Department of Medicine, to please felicitate Sri Chakrapani sir. Thank you, sir. To go ahead with the proceedings, I would like to request everybody present on the dais to go ahead with the lamp lighting ceremony in the traditional way. And Dr. Mova Gopal and the principal sir to please join us, and Dr. Nagaraj as well. And Dr. Srinivas as well. The lighting of the lamp marks the beginning of new ventures, dispels darkness, and illuminates our path of knowledge, wisdom, and hope. I would like to also request Dr. Jay Shankar from IIT to please join us on the dais, please. insights into being an intern, professional conduct, and clinical approach to patients with systemic illness. This knowledge series, part 4, is what we are here all gathered today to listen to. And to speak his heart out, we luckily to have with us Dr. Rajendra Kumar, IAS, an alumnus of All India Institute of Medical Sciences, New Delhi. And before that, I would like to request Dr. Krishna Rao to say a few words and share his thoughts.
And you have a slide change? Okay. Should fall. So the slide change this way? No, want to change the slides. Huh? My slides are there, no? Loaded. Yeah. Good afternoon, everybody. I know it's the afternoon session, and I'll try that you don't sleep. I know my afternoon sessions were very sleepy. Okay. So an investment in knowledge pays the best interest. This is Benjamin Franklin. I want to start off with that. So you are embarking on a journey when you're doing medicine. Medicine is fraught with intellectual challenges. Challenges of listening to patient. Now listening is a very important art. The listening itself, by the end of the fact that you have listened to the patient well and his complaints, you arrive at a differential. Which system is involved? Yesterday I saw a lady, she was having pain in her shoulders. I tried to understand, and she was having pain in the back, and she was breastfeeding the child for more than a year, listening. Then I understood that probably she was not in the right posture when she was breastfeeding. It was really remarkable. She was breastfeeding her kid for almost a year. But then, listening. I listened and I said, probably your posture, correct your posture. All your shoulder pain, everything will disappear. Medicine is fraught with intellectual challenges, challenges of patient listening, keen observation. You're always observing the behavior of the patient. Analytical skills. After you have listened to the patient, observed him very well, then your analytical skills comes in. The diagnosis is made after that, and therapy as in treatment. Now, what I want to share with you is, whenever I listen to a patient, and he tries to show me the report, I never see the reports. Why? I get biased. I have my line of thinking. I'm developing on which system is involved. Suddenly the reports pop in, and I get confused what I was thinking. I'll never see the reports of the patient when you were seeing the patient. Write down your findings, write down your clinical impression, write down your possibilities, and then see the reports to see whether what you are seeing and what you thought and what the reports are conversant, or you have missed something. So thinking is a very important part with the analytical skills. For medical interns, the key advice is to be highly observant, actively engage with patients and their families. So most of the times, you get the family history. The patient may not admit he drinks alcohol. He'll just say, I don't drink at all. Like 2 days back, I saw a patient, a young software guy, and he was a smoker. When I asked him how many cigarettes you smoke a day, he said 4. His wife corrected me, a pack a day. I immediately know chest tightness. Before chronic obstructive airway sets in, the patient has bronchospasm of the small airways. which may not present as wheeze. That may be an early sign of COPD, chronic obstructive airway disease. So you are highly observant, actively engaged with the patients and their families. His wife pipped in. Ask questions readily. So keep on asking questions. And first is what the patient tells. Second is what you ask directly. Ask patients readily. Be a team player. Prioritize learning over immediate tasks. Prioritize learning over immediate tasks. Manage your time effectively. So it's very important that once you're in the hospital, try to be punctual, because you get this 5 minutes extra. Manage your time effectively and always maintain professionalism and ethical conduct. Essentially, use your internship as a crucial learning opportunity to bridge the gap between theory and clinical practice. Now, I've come across people who are very good at theory, parroting details, parroting journals. Actually, is when they see the patient, when they touch the patient. Somebody may not be good at remembering certain criteria, but then when he sees the patient, he's able to diagnose critically. So the clinical is a different aspect. Theory is a different aspect. Generally, if you're good at theory, you are applying the theory to practical aspects. So theory is a back job, the background job, but application of knowledge. So internship, crucial learning opportunity to bridge the gap between theory and clinical practice. I gave up my life to learn how to save yours, isn't it? The grilling, the grinding that you're going through. In selling as in medicine, prescription before diagnosis is malpractice. This is what malpractice, that's what you have to be careful. Be ethical in your approach. What happened? Next slide. Yeah. So clinical skills. Patient assessment. Thoroughly examine the patient. Be systematic. When I see the patient, I do commit, I write the findings as a general physics examination, chest, cardiovascular, and upper abdomen. I write my findings. Once you're examining a patient, writing down the findings, you're committing yourself to a certain possibility. There is a lymph node, there is a lymph node. I commit myself to that. Commit yourself. That's how you learn, because if you miss it, you'll be correcting the mistake. So, patient assessment, thoroughly examine patients, take detailed histories, learn to interpret clinical findings. Now, as a resident or as an undergrad, I would say you go down to the ward, see patients yourself, take the history, undergrads or even postgrads as well. Write down your findings bit by bit. These are my chest findings. I suspect a bronchial breathing on the left infra-axillary area. Write down your findings. That's what you felt. Commit. Then you read the case sheet. The case sheet was written by a postgrad, and he would have written the correct findings and the correct interpretation. So you have trained yourself in picking up the findings. If you pick up the finding, you get the right history, you know the system involved. Diagnosis means I think 60% of the job is done. 40% you can read and treat. No big deal. Learn to interpret clinical findings. Communication. Practice clear and concise communication with patients, families, and other healthcare professionals. Now, what I find these days, the doctors of today, they hardly communicate with the patient. The patient tells something mechanical like a robot, they'll write a prescription. No, you have to touch the patient. You have to examine. With your touch, with your empathic approach, the healing begins. That's very important. Like there was an old lady I saw, I put my hand on her head and said, in your age, even my knees will go. And she was happy. Iska bhi yahi haal hoga. He'll also go. So you immediately develop a rapport and a bond with the patient. The bond with the patient, the healing starts. So communication is very important. You should ask how you are. If the attendant tries to chip in, say, just keep quiet, let me listen to the patient. After the patient said everything, yeah, I'm having pain here, pain there, I'm not being able to sleep, then you listen to the attendant for the add-on finding. First, you talk to the patient. So communication is a very important skill. Communication, practice clear and concise communication with patients, families, and other healthcare professionals. Procedure skills. Actively participate in basic procedures like IV placement, wound care, and medication administration under supervision. Learning approach. Ask questions. Don't hesitate to ask questions even if they seem basic, to fully understand diagnosis, treatment plans, and patient situations. Now, I believe that whenever anybody asks questions, I always say no question is stupid. This person is asking a question because that person has a genuine doubt. To a knowledgeable person or to this thing, it's never a stupid question. I will address the issue. Why you thinking like that? Maybe in asking the question, that person has some point which I'm not able to understand. So no questions are ever stupid. Be patient enough to address it, to mitigate it, to explain. Sometimes the person asking the question may be right. He may be having a point. You know, then you say, okay, let me read up and get back. And you also read up and get. That's how the education has to go on. Active listening. Pay close attention to patient concerns and actively listen to the narratives. You know, sometimes the narratives may seem stupid, sometimes they're irrelevant, but you may be getting a psychological issue in the entire process. And sometimes you may be picking up flight of ideas when the patient is talking. Why he's talking like that? Why? What's wrong? A kind of this thing will come that, okay, when I go, I forget where I kept the keys. I forgot my address once. This is naturally, the patient is transmitting this information to you. But what should be in the back of the mind? Am I dealing with Alzheimer's? Does this patient have Alzheimer's? Get the point? So it's very important to talk to the patient, to understand, to listen what he's trying to say. Active listening. Pay close attention to patient concerns and actively listen to the narratives. Self-study. Regularly review medical textbooks and online resources to reinforce your knowledge. Now what I would like to say is, even now I study. Even now I read. So what I do is, I haven't got that. I make Venn diagrams. I write down what I read with my pen. Very easy for me to revise. I come down to memory techniques in the end. I teach you how to have memory techniques. So once I write, and then there's something called a Feynman techniques. We have read something. You take a register and try to recall what you have gathered from your reading. First reading, you can't understand anything. Second reading, little bit. Third reading, you start remembering things. Memory is very important. So, and there is no replacement to self-study. Unless you study yourself by listening. Now these the YouTube videos have come. So whenever you are there, like one of the memory techniques which I'll talk later is that a person who narrates the answer on the mobile phone, and while sleeping, he allows that mobile phone to play his recording, and he has better memory the next day for the entire process. He sleeps with his narration. So it's talking about sarcoidosis, talking about lymphoma. He listens to the conversation and he sleeps with it. That gives you a better memory. So self-study, no substitute to self-study. And it is said if you study today and you read next day by evening 6 p.m., the retention is 60% in memory. You read today something, and then next day 6 p.m. you revise it, the retention is 60%. A wise doctor wrote, so this is the problem with all of us. We write something, only the pharmacist can understand. I remember my undergrad days, I had a friend whose father was a doctor. Those days they used to send letters, you know. We didn't understand. He used to go to the pharmacist shop and say, tell me what my father has written. So doctor's handwriting. So the IMA guidelines say you write in capital letters. Professionalism, punctuality, arrive on time for shifts and meetings. So, you know, absolutely on time for shifts and meetings. Appearance, maintain a neat and professional appearance. Ethics, always prioritize patient confidentiality and ethical decision making. Teamwork, collaboration, work effectively with attending physicians, nurses, and other healthcare staff. Now remember, as a doctor, when you are practicing medicine in a hospital, you should focus on building teams. The team is, nursing professionals involved, everybody, anybody who's, you are discussing the possibility, because sometimes the nursing professionals tell us, they have observed certain behavior and they'll discuss with you. Start thinking, aise kyo kiya, aise kyo kiya, aise kyo kiya. You're thinking, and maybe you're revising the diagnosis. So it's a team, and in the process, you teach them also something. Respectful communication, communicate respectfully with colleagues, even when facing challenging situations, you know. Do not get provoked. That's what I would tell you. If somebody's trying to provoke you, don't get provoked. You are focusing on work. Do not get provoked. And if you're not provoked, you have won the battle. Optimum nutrition is the medicine of tomorrow. What happened? Lights gone? No, I'm sorry. This is So the effective communication is, that the patient understands you have developed a rapport. The rapport is where next time when the patient comes to the hospital, he'll ask you by name. I only want to show him. You have been an effective communicator with the patient. He said, no, I don't want to show anybody. I want to meet that doctor only. Because you have established a rapport or a bond with the patient, that and the patient feels very at ease to discuss things with you. Like yesterday I saw a patient and I was thinking. I was understanding. And I gave this advice on lactation, long periods of lactation, 1 year. Then I tried to read about it, that a mother can breastfeed the child for 2 years or more. It's absolutely normal. But then she started having shoulder pain, back pain, leg pain. Then I was like understanding the situation. Then I thought, is it a wrong posture where she is breastfeeding the child? Optimum nutrition is the medicine of tomorrow. Time management, prioritization, understand which tasks are more important and prioritize accordingly. I would suggest that when you are doing the work in the wards, write down the names of patients, beds of patients, and what reports are to be collected as interns, and which is an important priority for the next day, and why the patient is doing something. So what I used to do in the hospital was, I used to see the patient, I used to come back for an evening round. I was not on duty. I used to just go and stand at the bedside of the patient and try and understand what I have missed. Have I missed anything? I would re-examine the patient again, get my findings, and I will just think, have I missed out on something? And that is what makes you a good clinician. The more time you spend with the patients, on the findings, on the history, makes you an astute clinician. And that is where there's a paradigm shift on evidence-based medicine. But I still feel you have to be a good clinician. Patient talks and you know. Are you slurring? Did you speak like this before? Why are you slurring? That's an observation. Don't go to an MRI report to realize that this slurring was because of the MRI said me so. You observed, this is like slurring. His walking is slightly difficult, he's slightly this thing. So you have to be observant. You have to be a good clinician than evidence-based medicine. Of course, to prove or disprove, you go down to the test. But then, before the test, you're writing your possibilities. I always write clinical impression. 1, myositis. 2, can it be query hypothyroidism? 3, could it be query tuberculosis? I have committed myself to my diagnosis without just history examination. I have not seen the test reports. But then I advise the test. When the test reports come consistent with my diagnosis, I am jumping up. Medicine is one field where you jump up when you get a correct diagnosis. Is bad news for the patient, but good news for the doctor. Because that's what he thought. He's jumping up. Wow, that was my possibility. So, when you have committed yourself in the prescription, like clinical impression, 1, tuberculosis, 2, sarcoidosis, you've done a good job. That's your thinking process. And as a doctor, I know by the way you write prescription how much knowledgeable you are. And then I simply read the prescription. I say, this guy is good. He's applied his mind. He's seen all the reflexes. So unless you practice your skills, you won't write these things. You would not look for. I remember I saw a patient long back who I got the habit of examining every patient. A tiny lymph node on the, here, supraclav. And in the right side, and my other said, there's nothing in it, right? I said, nope, I want it biopsied. Turned out to be adenocarcinoma. If I had not looked for it, I would have missed it out. Tiny lymph node, you would ignore it. Turned out to be adenoCA. Had an ovarian cancer. What I'm saying, because of the habit of your clinical skills that you're picking up findings, you're committing yourself to findings, you're picking up important diagnosis and the treatment. Organization of work. Keep detailed patient records and maintain a structured approach to your work as part of legal record. I remember when I was doing medicine, the first HIV patient at that point of time was an ambassador of a country. And that patient, in Ames, I got a call, I had to give CPR, and that was HIV positive ambassador of a country. And everybody knew in the hospital that private ward 210, whatever, is an HIV. There was a new HIV then. And I'm talking about 91. Then every minute I had maintained a legal record in the note sheet called the anesthesiologist, called this. Now what happened with this, if you Google it, I don't know if it's there, that body was sent to Lady Harding Medical College without the label of HIV, which means they embalmed the body without the label of HIV. It was a huge, this thing, if you wrote in the newspapers. And I was called by the Government of India Inquiry Committee. I said, whatever I have to say, I've written the note sheet. So, note sheet is a legal record. And nothing happened. I said, you read the blue book. It's not my duty to embalm the patient. It's a legal record. Note sheet is very important. Write down whenever you see the patient, when you're on duty. Like what would you do sometimes as an intern, as a doctor, you're woken up at 4 a.m. What would you do? 4 a.m., you're at the spinal level. Brain is stopped functioning, you're very drowsy, you're very sleepy. Just go and record the blood pressure of the patient. If the blood pressure is okay, vitals are okay, you can give this symptomatic treatment, go back to sleep. If the blood pressure is down, then you have to be totally awake and see why she's hypertensive. It could be pulmonary thromboembolism at that point of time, it could be anything, PT presenting like that. So that is the time when you should just record the blood pressure. Even at home also, 4 a.m. we're going to just record the blood pressure first. Blood pressure is normal, 99% of things the patient will be fine. The pulse rate is normal, right? Pulse rate will not be irregular and things like that. Be observant, notice subtle details in patient presentations and clinical findings. Seek feedback. Actively seek feedback from attending physicians to identify areas for improvement. So, you know what I remember when I was in casualty at AIMS, you know, and in one night I diagnosed 6 meningitis. One of them had psychiatric symptoms. And I insisted by the resident, no, I want a lumbar puncture on this patient. And it full of bacteria, the LP, you know. And next time the neurologist would cross me and say, "Cha gaye boss," you know. In Hindi they say, "Wow man, you are amazing." Because I called him 6 times the whole night, 3 a.m., 4 a.m., 5 a.m. Each time it turned out to be bacterial meningitis presenting at that. So, you know, because you're clinically good, others respect you. What happened when I was working in another hospital, there was a patient I saw, I got a call. Okay, this patient is anuria and bradycardia. Anuria, bradycardia. I got the potassium done out of my clinical sense, 8.5. I became a hero of the hospital. Faculty members started bringing their parents to me because they knew my clinical sense was good. I picked up hyperkalemia. Immediately put on 20 units of insulin, 200 ml, 20% dextrose, 20 minutes, and calcium gluconate. Patient survived, and I became a hero of the hospital. Everybody. So what you do, what you clinically diagnose, makes you stand apart in the hospital, that you are good in your clinical sense. We don't need so many super specialities these days. That is the thing. I feel you need a good internist. A super speciality is important when the internist raises his hands up or wants an expert opinion. But you should come back to an internist. Let the internist collaborate on any patient, okay? Embrace challenges, view challenging cases as learning opportunities to develop your clinical reasoning skills. So whenever you see a difficult patient, make a note. What difficulty you saw, what were the findings, you know? Draw a diagram. It probably has a patch here. Chest X-ray comes consistent with your findings, you know. Now, would there be a fever for that matter in a lady who is about 75-year-old? No. In a lady, a woman who is more than 75, fever is not an important symptom, yet she may have a huge consolidation. Why? Because all these elderly people who are about 65 years and above are immune compromised. I just saw a patient and I found a bronchial breathing on the left infraxillary area, and she didn't have any fever. The attendant said she didn't have any fever. I said, don't care about fever. At this age, I don't expect fever. She may not have fever and have a huge consolidation. I treated her with septum and clarithromycin. I wanted to take her viral pneumonia as well. You know, so, you know, fever may not be an important sign in old people. Embrace challenges. When you see a difficult case, every day you should try to go and see a difficult case in the ward, read about it, make notes about it, and you'll remember the case. Manage stress. Develop healthy coping mechanisms to manage the demands of internship. Reflect on your learning. Regularly reflect on your experiences, identify areas where you can further develop your skills. So this is basically, medicine is what? Medicine is a skill. As you grow up, as you do post-graduation, you are developing skills which will have a monetary value. Monetary value is one aspect, but the other aspect is because your skills are good, you know, like I remember in the pediatrics ward for that matter, it's very difficult to put a butterfly cannula in children, very neonates, you know, and some nurses are so good at it. I struggled, I couldn't, and the nursing professionals are, doctor, I'll do it for you. Tuck, went in, skill. You are going to develop skills, you're going to get paid for skills, you are going to get recognized for your skills. That you have a very sharp skill, you put the step, you say this is my diagnosis. This is a skill. Manage stress, reflect on your learning. Identify areas where you can further develop your skills. The inventor of automatic machine gun, Hiram Maxim, spent so much time test firing his guns that he became profoundly deaf. His son, Hiram Percy Maxim, eventually invented the silencer, but too late to save his father's hearing. This is an interesting fact. Medical students are not interns. An intern is a first-year resident. What I want to say is that you are learning every day, every minute. I'm learning every day, every minute. My learning never stops. Make friends with the nursing personnel and respect them. Do not yell at the nurse or any staff, as they can literally make your life a living hell, because they will not report to you if something happened. You will go to the ward, you won't know, but the sister would, you're friendly with her. She'll tell, doctor, that bed number 29. I remember this patient who was very happy when I went for the evening rounds. He said, Doc Sahab, I won all my court cases. I said, wow, good. Go home tomorrow. We're discharging you. Next morning I came and his bed was vacant. So I went to the sister, bed number 29, did he go home? Sisters told me, don't you know what happened? What happened? He lost his life last night. Probably out of happiness, he had a severe heart attack. You know? So have a bond, have a team. Do not yell at a nurse and his staff. A nurse has a lot to teach a first-year resident. I told you about the butterfly cannula in pediatrics, you know? She helped. So be humble, listen, watch, and ask them to teach you something. Always be early. If you're on time, you're late. You should be in time. In time is before time, 5 minutes before. You should be 5 minutes before. I remember I was in the US. My best friend is in Case Western Ohio. He's a gastroenterologist, hepatologist. He may win the Nobel Prize. He's working on sarcopenia and cirrhosis. He would always go before time, 5 minutes before, see his patients. Steve, in this age, he's damn punctual. He's one of the big guys in the US. He asked me to do the USMLE. He said, I'll send you to Harvard or wherever. He's a big guy in the US. But time, he's very punctual. Early means being the first one of the team there. Know your patient's history. You'll be asked about it. So you should read the case sheet, know your patient thoroughly, know the patient findings. That will be on the tips of fingers, you know. And if you read the case sheet 2-3 times, you'll be conversant with it. You look for the finding. You should tell the senior if you missed something. Sir, very humbly, sir, I think there is a scratchy pleural rub here. Would you just confirm for me? Don't say you have missed a pleural rub. Because senior is a senior. Be humble. Sir, I think I'm getting some pleural rub. I may be wrong. Can you just confirm it for me? That is the approach with the senior. Don't try to tell sir you have missed a pleural rub for that matter. Know your patient's history. You'll be asked about it. When asked how you would handle the patient, always start off your answer, I would do a good history and physical examination. Then you could go on with, based on history, I would to examine for ABC. First, a good history and physics examination, the foundation for any care rendered, and will always be respected as an answer, especially by senior staff physicians. What happens when you become senior? You'll not become senior one day like I am. It's natural, you know. I'm growing old. You'll be responsible people. You'll expect this from a junior tells you, sir, I got this tenderness here. You're very happy this junior has eased your pressure. He has picked up a finding and you're going to confirm it. I think you're right. You know? And the other thing I realized in medicine was knowledge is power. I remember my hospital when I was senior resident, and I was having rounds with my professor with enteric fever, and he was bleeding from multiple sites. This patient of mine, I told my professor Ma'am, I think she is entering with DIC. My professor, Dr. Rajendra, how many patients have you seen? I said, obviously, ma'am, you have seen more patients than I have, but this is my clinical hunch. In the evening, the reports came consistent with my diagnosis, and my professor started respecting. She used to always start saying her patient, Dr. Rajendra ko dikha do, Dr. Rajendra ko dikha do, unko dikha do, unko dikha do. My professor had faith in my clinical sense and abilities. Because I sent the test reports, evening reports came consistently what I had thought, and so when asked a good history, physics examination, the foundation for any care rendered, and will always be respected as an answer, especially by senior. I still remember I was on the rounds, and there was this patient who was having cervical spondylosis. He was 78-year-old, and my co-residents, my junior residents told me, sir, I think it's spondylosis or AIDS. I said, no, I want an ECG. Frank inferior wall MI. Because I suspected, I said, no, this is severe. Frank inferior wall myocardial infarction. Unless I look for, I won't find the diagnosis. Unless I think, I won't get the diagnosis. I look for it or got the diagnosis. Second, it gives you time to think what they are really asking you. I think it is possible for ordinary people to choose to be extraordinary. All the doctors here, we are all extraordinary. We are a hero in patient's life. We are fighting for a patient's life. The attendants ask, Doctor, report kya hai? We are answering. Okay, this is a pneumococcal chest infection. Don't worry, I've given the best antibiotic. You are fighting on behalf of the family. It's very important when you're saving a life. Who knows? You are saving a bread earner of the family. You're saving a mother for the children. So how important you are. So you are extraordinary. This slide. Yeah. Blank? Huh? Okay. But with the other slides. Okay. Yeah. In addition to comments about dealing with, I would also like to add is sometimes appropriate when you are one-on-one with the nursing team to ask what they think. You have the right to disagree and discuss, but that conversation can give you valuable insights. I told you, you should talk to the team around, the sisters around. The patient ko kya hua? Raat ko isne kya kiya? Sister will tell, this patient didn't let us sleep us in the night. He was acting weird. You get your point? Why is he acting weird? I will go for a sodium check. Is it having hyponatremia? I remember I saw an old lady 2 days back, and she had pneumonia. I immediately put her on sodium. I said, Bicosul ka capsule khol karke, put salt in it and give her twice a day. I'm checking the sodium, I'm correcting hyponatremia. Because she has pneumonia, she will have SIADH, serum inappropriate ADH, which will lower down the sodium. So I'm correcting her sodium before. So, right to disagree and discuss. Having to defend your position will make you think like a clinician and a very good exercise. Now what happens when I see a patient, I diagnose the patient correctly, and I put the patient on treatment. 2 days later, I get the feedback, patient doing well, I get very happy. Wow, that was what I thought. Patient doing well, Build a team. Team stands for together, everyone achieves more. Team. A harmonious team will save more lives with a less blame game. What happened to my slides? No slides? Okay. Okay. Violet Jessup, a ship nurse, served on each of the 3 sisters, Titanic, Britannic, and Olympic. While she was on board, the Olympic collided with the warship and nearly sank. The Titanic hit an iceberg and sank, we all know. The Britannic hit an underwater mine and sank. Violet survived all 3. It's a very interesting fact. What's gone wrong? Can you do it with the button there? Maybe there's problem here. third man syndrome, also referred to as unseen presence syndrome, is a phenomenon reported by adventurers and explorers in survival situations. These individuals describe an unexpected visitor or presence who provides practical advice and encouragement during the traumatic experience. For that matter, if you read about the Mount Everest, there are a lot of mountaineers who could never go on the mountain. They died on way to the Everest. Now they are landmarks for further mountaineers to find their way to the Everest climb. Like they always say, there's a green guy who is lying frozen. So you go and take a left from the green guy. This guy is dead on the Everest, you know. Clinical eye openers, I'll briefly touch on them. Not all angels have wings, some have stethoscopes. Okay? You should be proud that you are a doctor, because socially you'll always be respected. Emotionally, you're always treating somebody and taking away somebody's pain. And there's no age of retirement in medicine. If you're good, you're good. You can go on practicing till 84. And the more older you are, the highly respected you are with your clinical sense. The 4 stages of a morning lecture. Thankfully, this is an evening lecture, not a morning one. Now, medical fact. Hematidrosis is an extremely rare illness that causes a patient to sweat blood. It occurs when blood capillaries that supply sweat glands break. Symptoms include blood oozing from umbilicus, nails and forehead, and other skin areas. I've never seen this patient, but I did come across this. I thought, you know, you must be aware some people can sweat blood, don't get shocked. You know, but if it's sweating blood from here, you're not worried. If he's getting blood from multiple sites, you worry. Simply we used to say how many cell lines involved. Fever for neutrophils, bleeding for thrombocytes, infection for, and anemia, blood loss, pallor from anemia. So we also say how many cell lines involved. How many cell lines involved? 2 cell lines involved, 3 cell lines involved. We really know. Are doing aplastic anemia for that matter. You know, fever because neutrophils are dysfunctional. So if blood is going from umbilicus, nails and forehead, then you know that we always say that multiple site bleed. Then, you know, we know it's a different thing. Studies show that cats understand human commands but don't care to follow them. You know. Liver disorders. I'll just share a little window. So yellowish discoloration of tissues resulting from, all of you know that. But then where is the earliest spot where you see the bilirubin? It is the frenulum of tongue. Okay? Normally you see it at 2.53, but even before that you can pick up jaundice in the frenulum of tongue. Normal is this, jaundice seen value is 3 mg per deciliter. Only conjugated bilirubin is water soluble. Unconjugated bilirubin bound to albumin cannot pass into urine. Conjugated bilirubin filtered by kidneys appears in urine. Thereby urine bilirubin is always pathological. Then jaundice can exist without liver disease, seen in hemolytic anemia. Hemolytic anemia is what? I'll come to that slide. Genetic conditions like Gilbert syndrome, and not all jaundice is liver failure. Pain versus painless jaundice is a major clue. Painful jaundice is stones. Painless progressive jaundice, think malignancy. Now if suppose the 85-year-old person has pain, you know, in the right hypochondrium, and has progressive jaundice, I immediately give pancreatic cancer. I immediately see there's some kind of malignancy you're handling, you know. For that matter, if an more than 65-year-old female patient or male patient has a seizure, any seizure beyond the age of 60 is metastasis, METs, because the patient never had a history of seizures and is having the first seizure at age of 65. It has METs. You look for where's the primary. Hit for the primary, you know. Jaundice affects skin differently. Best seen in sclera and soft palate. Soft palate was the frenulum of tongue. Harder to detect in dark-skinned individuals. So check under natural light. That's very important. Now, with the pre-hepatic hemolytic jaundice, you have increased unconjugated bilirubin, normal liver function test, no urine bilirubin, increased reticulocyte counts because of hemolysis. Red cell destruction, the marrow gets stimulated to form more RBCs, the retic counts increase. Can you shift? I think it is getting stuck. When you get your phone repaired from a local shop, you know, you gave an apple, turns out to be Samsung, my Apple phone. Strong. High affinity to elastin-rich tissues. So best in upper sclera, palate, undersurface of tongue is frenulum. Okay. Now, as a clinician, you have to, any patient where you suspect, you move hollow and try and observe there. Once you start observing there, you will pick up the finding. And then you will demonstrate, look here, I think this patient has jaundice. The frenulum of tongue is slightly yellowish, that way. Clearly seen in daylight, difficult to see if room has fluorescent brightening. Is something wrong? Achha, this is forward? Okay. So PT oblique ALT. So this PT oblique ALT, this is very high. ALT is very high in liver disorders. Primarily liver disorders, ALT is very high. And so P or A, L you should remember. 30 to 50 times infectious toxic hepatitis. So what I'd like to say is like moderate increase in hepatocellular disease, lower ALT levels in alcoholism. This is very interesting. I'll come down to the next slide. The simple act of caring is heroic. Albumin levels. What are the prognostic markers in cirrhosis? You see a lot of cirrhosis here, isn't it? I'm sure you must have seen a lot of cirrhosis. Once you see the cirrhotic liver disorders, what I look for is the albumin levels. If the albumin is good, suppose you see in your family somebody has cirrhosis, I only look for albumin. If the albumin is good, I know the liver is still synthesizing albumin. So liver is preserved, okay? Prothrombin time is normal, I know liver is doing its functions well, the protein synthesis, Sodium deficit, if you find in a patient who is cirrhotic, is bad. It's a black problem. Should know about his prognostic markers. When you see at home or nearby, try to make a table and try to start thinking what are the prognostic markers. Hepatorenal syndrome is another this thing which is a bad prognosis. High bilirubin has a worse survival. Creatinine, high creatinine is hepatorenal syndrome, strongest predictor of mortality. And a woman with cirrhotic liver disease, somebody told me she has not passed urine for the last 24 hours. I immediately know it's gone into hepatorenal, may not come out. It's a bad prognosis, So you should be activating knowing these things. Try to see patients' reports, your relatives' reports. Try to do an analysis. Look for this prognostic marker. Then you know. Or you can tell your mom or close that, if it's difficult, he'll survive. But unless you know, you won't analyze it. Thrombocytopenia goes with portal hypertension. High red cell width, emerging marker. It's one of the emerging markers. ALT or PT and GGTP go together. If ALT is high and GGTP is high, we know it is liver origin. Okay, ALT or SGPT. AST is more than ALT in alcoholic liver disorder. This is very paradoxical. AST is more than ALT in alcoholic liver disorders. AST is high in muscle, liver and other tissues. So if AST is high or OT is high, it is non-specific. Muscle, liver and tissue. If ALT is high, it is only liver, predominantly liver. Oh, I'm sorry. Yes. So gamma glutamate transferase. So if ALT is high, GGT is high, you know it's liver origin. GGT supports the liver origin. ALT is high, the increase in cholestasis confirms raise of ALP of ALP is of hepatobiliary origin. Isolated rise in alcohol abuse, monitor cessation of alcohol consumption in chronic alcoholic. Now see the stages of alcoholism. If you read the stages of alcoholism, you should listen to that. Stage 3 is when the patient starts drinking with somebody below his social level. He calls his driver, come, have a drink with me. That's a warning sign that the alcoholism is going out of control. You should immediately plan the addiction for him. Alcoholism going out of control because he's drinking with the gardener for that matter. He calls a gardener, come on, let's have a, you also have. There's no, drinking is get out of control. 4th stage is when he gets up in the morning, opens the alcohol bottle and drinks till his stomach calls stop. That's stage 4 alcoholism. So if you come across these situations, you immediately know that this thing. Of course, the other thing is alcoholic jealousy, wherein most of these alcoholics, they beat their wife because they have more estrogens, they cannot perform sexually, they suspect the infidelity of the wife, so most alcoholics, for alcoholic jealousy, beat their wife. They suspect the fidelity because they cannot. So, because you have testicular atrophy as a symptom in cirrhotic, isn't it? The finding cirrhotic disease. LDH, ALT by, I'll go on to the next slide. When you don't know what to answer, but you refuse to leave the question blank. Now, I was an examiner of MBBS answer sheets at one point of time. Let me tell you, it's very, very boring to judge answer sheets. At one point of time, I picked up the scale and said 6 centimeters, but it's so boring, they're not written anything. We're trying to pass them, you know. So, I mean, in the answer also, when you're writing answers, do a topic-wise. What is the pathophysiology? 2 lines, 2 lines. If you've written something, the examiner will give you marks. The chapter you are learning today is going to save someone's life tomorrow. Pay attention. So, ALT or PT, an enzyme that helps convert proteins to energy for liver cells. Alkaline phosphatase, found in liver and bones. So here, ALP is high, you know, liver and bones. If ALP is high, alkaline phosphatase is high, you would like to even do the calcium phosphorus and SAP. SAP is this one. Calcium phosphorus is osteomalacia, you know, you like to do this. AST/OT, an enzyme that helps the body break down. Try to read. I read every day. Try to read, make notes. Knowledge is infinite. And you don't know, any knowledge can save a life someday or make an important feature. I remember Dr. Srinivashan Dashrathi, my best friend who is in Case Western Ohio. What a learner. And he reads every day. He's such a big guy that whites come down to his lab and beg hands, says, sir, please give me an exposure in your lab. The white guys in America. He's such a big guy. What a genius. He's written a chapter in, if you're familiar with textbook of hepatology, he's written a chapter in the World on liver coma, for that matter. Shall I go? What are you doing? What's worse than heartbreak? Heartbreak. Changing the answer on a test that was originally correct. It happened with me. I cut it down, wrote something else. What I wrote before was correct. I was like, oh my God, I lost marks. Asthma tidbits. So all of you know, it's V, shortness of breath, chest tightness. So I told you, I just came across a young software engineer who smoked about a pack a day and was complaining of chest tightness. I immediately started on bronchodilators, empirically, because the earliest sign is chest tightness. The smaller areas are involved, there may not be any V's. So very early, there may not be any V's. There will be a chest, you may not have any finding, yet there's chest tightness. And the other extreme is a silent chest. Severe asthma, and there's a silent chest, no V's at all, you know. So these are the two. So I put him on a bronchodilator. I said, go on this. Cough that vary over time and intensity together with variable expiratory flow. Exercise-induced asthma. You must have come across your friends. It happened in my childhood as well. There was a certain boy who ran with me, played football, started wheezing. That is exercise-induced bronchoconstriction. Exercise-induced bronchoconstriction, the clinical history findings are typical of asthma, but are associated only with exercise. Initially, airway dilatation is noted during exercise. If exercise continues beyond approximately 10 minutes, bronchoconstriction supervenes, resulting in asthma symptoms. Exercise-induced asthma, anybody doing? So if you come across somebody who ran or was done marathon, after 10 minutes starts wheezing, it's exercise-induced asthma. If exercise period is shorter, symptoms may develop up to 5 to 10 minutes after completion of exercise. Higher intensity levels of exercise result in a more intense attack, with running producing more symptoms than walking. What I'm trying to sensitize you to this kind of asthma as well. By this slide, there's exercise-induced asthma as well. If you come across somebody who runs and develops wheeze, develops breathlessness, it's exercise-induced. A history of choking sensation in exercise, respiratory wheezing. The athletes who are more physically fit may not notice typical asthma symptoms and may report only a reduced or more limited level of endurance. So that's how you pick up. Or somebody 100 meters practitioner, athlete, says I'm not, when I run in the last 20 meters, I feel really suffocated. Maybe exercise-induced asthma. You know, you need to, this thing. Limited level of endurance is also a symptom of exercise-induced asthma. Cold, dry air generally provokes more obstruction than the, where are the pyramids in Egypt? Because they're too big to transport in British museums, you know. Clinical. Now severity, I'll just explain, you know, I applied my mind to this slide and I understood. What is the severity of asthma? Mild end expiratory wheeze. End of expiration, you get a wheeze. Then moderate, you have only expiratory wheeze. Entire expiration, you get a wheeze. Severe, you get a wheeze in inspiration and expiration. End expiratory, only expiratory. Severe is both inspiratory and expiratory. If you get this, you know it's severe asthma. And then, of course, at the end, you have a silent chest. The chest, there are no sounds. So, wheezing, in mildest form, wheezing is only end expiratory. As severity increases, wheeze lasts throughout expiration, moderate. In more severe asthmatic episode, wheezing is also present during inspiration, inspiratory and expiratory. During a most severe episode, wheezing may be absent because of severe limitation of airflow. So, it's a silent chest. Asthma can occur without wheezing when obstruction involves predominantly the small airways. That's what I was telling you about. Chest tightness. This is because small airways, there may not be any wheezing. Still it will be asthma or COPD for that matter. This wheezing is not necessary for diagnosis of asthma. Cough may be the only symptom of asthma, especially in cases of exercise-induced or nocturnal asthma. Now I pick up smoking a patient, they get shocked. How do you pick up? I look, see clubbing here. I tell him, do you smoke? The patient tells, how did you know that? I know, because you're clubbing, you smoke. You know, how many packs a day? Other is the smoker's cough. You have to just get used to that cough. Immediately somebody coughs like that, we know it's hollow. It's a smoker's cough. Cough is non-productive and non-paroxysmal. Children with nocturnal asthma tend to cough after midnight. So if there is a small child at your home and coughs in the morning, is early hours of morning, it has asthma. The child coughs in the morning, sleeps night, in the morning is coughing. Probably the childhood asthma. Chest tightness or history of tightness or pain in the chest may be present in exercise-induced asthma or nocturnal asthma. So chest tightness is very important. Anybody say chest tightness? Try to get into the history, try to auscultate, try to ask the history of smoking or asthma in the family, and maybe you can give a bronchodilator and see. Maybe the patient improves. So this is mild, moderate, severe. Nothing much. Accessory muscles respiration are not there in mild. Heart rate is less than 100. Pulses paradox is not seen. Auscultation is end expiratory. Basically, remember from the bedside point of view, end expiratory, full expiration, inspiration, expiration. Mild, moderate, severe. And silent chest. The chest is totally silent. Is ultimate, this thing. So, and of course, pulses paradoxes and all that. CO2 retention is sweating, palpitations, is carbon dioxide retention, you know. That's a bounding pulse, pulses paradoxes, all these findings. So unless you look for, you won't find a finding. If you just pass on like that, and you will, because I looked for, I got a finding. Let me see. At least examine one patient thoroughly a day. Any patient thoroughly examine him one day, very systematically. GP, chest, cardiovascular, for abdomen. What are your findings? Note down a register. And then read the case sheet. You are developing your clinical skill. Because once you have become a doctor, or once you have become a postgraduate, nobody is going to guide you. You're on your own in the market. You are going to sweat. How do I treat this? The pulse is not palpable. The blood pressure is going down. Unless you experienced here and know the methodology, you will just sweat. ChatGPT 5 minutes after talking to me, you know, the kind of prompt I gave, ChatGPT also cannot answer prompts. Waking up every morning is like, no. Hemolysis starter pack. Anemia due to premature destruction of RBCs from 120 days is hemolytic anemia. RBCs don't have a long life. Hemolysis starter pack, if you see these four, the RBCs are dying. Increased LDH, indirect bilirubin goes high, reticulocytes go high because marrow is in a panic mode. Haptoglobulin goes less. Now this is what you see a finding in any patient. You should start, like for that matter, we keep on doing HbA1c day in and day out, but there are certain reasons why it is high and certain reasons why it is low. So one of the reasons why the HbA1c may be low is hemolytic anemia. Second is chronic kidney disorders, where the HbA1c can be low. It can be high in iron deficiency anemia. So when we get HbA1c, we don't never look for these causes. Smear shows spherocytes, schistocytes, bite cells. Anemia plus jaundice combination is increased RBC destruction, increased unconjugated bilirubin. Classic triad, anemia, jaundice, splenomegaly. So this is what a basic idea you'll have. You'll pick up on the bedside. Effective medicine is just pick up on the bedside. You know, your clinical sense. Okay, where is this thing? Blood pressure measurements. Normally, measuring blood pressure in the supine position shows lower blood pressure reading. So the ideal guidelines are blood pressure should be examined in the seated position with the arm at a level of heart, with legs which are not crossed, and with a back support. That is ideal. It's not like you just go and random. If somebody, before you label anybody hypertensive, should be very sure. I always tell patients, if I get a high reading, I said, no, I don't want to label you. I want to see you next week. Because once I label them, that label of hypertension will stick for life. Anybody says, are you hypertensive? Yes, I am hypertensive. Before you give the label. So the ideally, blood pressure in supine position shows lower. That is why seating position has been taken when compared with seated position. The results reinforce the importance of following the international hypertension guidelines. Blood pressure must be measured in the seated position to ensure a correct diagnosis. This is what the international guidelines are, not lying down. BP is not constant. It follows a circadian rhythm. So now that is why AI has developed now. Artificial intelligence has become hypertension. AI picks up. AI picks up how? Suppose you want to pick up hypertension and mass hypertension. Record the blood pressure of anybody close to your family who is suspected of hypertension 1 hour after sleep. Generally with sleep, the blood pressure goes down. If the blood pressure is high when the patient, when that person is gone 1 hour after sleep, it is first possibility the person may end up having hypertension. That's indicator. So that is why lowest during sleep, dipping. There'll be dipping in blood pressure. Once you calm down, sleep, 1 hour later if you recorded, blood pressure has come down. It means this doesn't have hypertension. If the blood pressure is high at that time, it means he's going to have hypertension later on. For sure. Early morning surge, highest risk of stroke MI. Early morning, recently I saw a patient and I asked, what is the early morning? I have splitting headache here on the occipital area. Hypertension. I put a patient on. Hypertension is very easy to treat, not very easy to treat, but I'll tell you a mnemonic, which I remember, A, B, C, D. A for ACE inhibitors, oblique ARB. B for beta blockers. C for calcium channel. D for diuretics. A, B, C, D. Generally they say you use A and C for older patients and B and D for elder patients, or the other way around, sorry. B and D for younger patients, A and C for elder patients, because B and D cause lipid abnormalities, beta blockers and diuretics. You can afford that in a young patient. You know, A and C do not cause any abnormality in elderly. So ACE inhibitors and calcium channel. Simply you play with it. And these days the criteria is for acute hypertension. When these days the diagnostic criteria, anybody you see randomly has a blood pressure of 200 by 120. You immediately label him as hypertension. There's a current guidelines. And how do you treat acute hypertension emergency? Labetalol. 200 milligram BD twice a day, you know. Then you have other medicines, hydralazine, sodium nitroprusside, nicardipine, you know. All those other drugs are there. You should be aware. You will come across situation in the family, somebody comes and says, my blood pressure is 200 by 130. You should know this to treat. Nothing. You should just get labetalol. Patient should not have asthma. Start on labetalol 200 BD. Yesterday I saw acute hypertensive emergency. Blood was not going down. Put the patient labetalol in the morning, 140 by 90. So you should be aware, you know. Diastolic BP matters more in younger patients. So would you treat somebody, an elderly patient who has a systolic blood pressure of 200 by 80? Yes. Any patient who is above 65 or 60 has a blood pressure of 200 by 80, you will treat it. This is known as isolated systolic hypertension. Isolated because they are at more prevalence of strokes. So you have to treat at 200 by 80 blood pressure with medicines, you know. The diastolic is normal. These days the criteria is any diastolic over 85 you have to treat, isn't it? 89 is considered hypertension. But any elderly, 200 by 80, you have to treat. Diastolic, early vascular disease, elderly, systolic BP most important. Wide first pressure, arterial stiffness or arteriosclerosis. Diastolic pressure is higher in seated position and unsupported back may increase diastolic pressure, whereas systolic pressure is higher in supine position. Crossing legs may increase systolic pressure. So what I told you, arms supported at the heart level, patient in a seated position, legs not crossed, back support. That is ideal blood pressure reading. Okay. One reading is never enough. White coat hypertension, monitoring BP matters most. Check both arms once. There should be a difference of about 20 millimeters. Home BP is more than clinical BP for true control. Ambulatory BP monitoring is the gold standard. So now this is now devices come with the market where AI is being used to pick up hypertension, artificial intelligence. You have watches which pick up hypertension, erratic readings. Immediately the blood pressure shoots, a signal from the monitor goes to the doctor. He knows at this point of time your blood pressure shot up. AI detects white coat, which when you with the doctor, the blood pressure goes up, masked hypertension, and nighttime BP patterns. What I told you, suppose somebody at home and you suspect them of hypertension, record their BP 1 hour after they've gone into deep sleep. If that BP is high, you know this person has hypertension and you have to pick it up early. So, no talking during and between measurements, cuff at heart level, use correct cuff sign and positioning, back supported, arms supported, record exact reading, legs uncrossed and feet supported. The white coat effect is when the physician is present may lead to misdiagnosis of hypertension in normotensive patients. Sometimes people get scared, and so masked hypertension is normal in clinic, high at home. This is masked hypertension, high cardiovascular rate. Orthostatic hypertension, drop in BP on standing more than 20 millimeters systolic or more than 10 millimeters diastolic. AI in hypertension, remote patient monitoring. So this is the technology. You have to get used to the technology now, because you pick up by artificial intelligence in hypertension. Patients measure BP at home. Data is sent to doctor in real time. It's useful for elderly, chronic kidney disease, post-discharge follow-up. So remote patient monitoring is started. There are people, some guy came to me. He said, I use AI instruments in hypertension. This is my number. Any patient suspect, give me the number. I'll put him a monitor for 24 hours, 48 hours, 1 week. He charges something. We get the readings, we pick up early. Continuous BP monitoring, wearables. So this is a smart device, right? It picks up my blood pressure readings, my watch. Smart devices track BP trends over time, detect morning surges, nocturnal hypertension, non-dipping patterns, more accurate than single clinic reading. So this gives an entire picture over the last 24 hours how your blood pressure behaves, and here you pick up very early. AI is a decision support tool, not a replacement for doctors. I don't think AI can replace doctors because the interpretation is different. I've come across people now, when they're rich people, if they have read the AI and come to me, I tell them I'll charge you 20,000. Because AI cannot treat. There are a lot of variable factors that you chip in before you write a certain prescription. AI cannot treat you. If you get treated by the AI, now I'll tell you something, in the COVID time, everybody Googled, and they Googled and started on corticosteroids in COVID. Steroids brought down the immune response, all of them had pneumonia, and there was so much mortality. AI cannot treat. AI can suggest, but it's up to me to pick it up or not. There are a lot of variable factors for that matter. Like I said, a chest tightness can be sign of asthma. AI may not tell it, but I know chest tightness. Maybe am I dealing with early MI, or am I dealing with a COPD, acute exacerbation? AI is difficult actually. This is Samter triad of asthma, nasal polyp, and aspirin sensitivity. Aspirin exacerbated respiratory disease. So if you ever come across a patient who was given aspirin, developed bronchospasm, think of this. Look for nasal polyps. Look for aspirin sensitivity. Okay? Patient present with chronic sinusitis, recurrent nasal polyp, asthma triggered by aspirin. Adult 20 to 50 years of age. Now ventilator-associated pneumonia. Common organism is Pseudomonas aeruginosa. In ICU setting, onset late, 4 to 7 days after intubation. The early onset, these are strep, Haemophilus, Medicines Staph aureus. Late onset, Pseudomonas aeruginosa, Acinetobacter baumannii, Klebsiella pneumoniae. So basically, based on this, Like somebody told me, viral fever, why are you giving antibiotics? I said, doesn't a viral infection of the throat cause mucosal injury? It causes mucosal injury. On that, a bacteria is sitting to hit it. So why shouldn't I give antibiotic? Now people say, this is enclosed, this thing. A guy who has just done his BA in journalism is writing an article, misuse of antibiotics. What does he know about antibiotics? You know why there is a lot of mutation in our community? Because we are very high in population. We have a high herd immunity. So the bacteria mutates very easily to survive. The mutation comes in, So it is not because of antibiotics. The bacteria mutates because that's why in the time of COVID, we had a very high herd immunity. So COVID couldn't affect us later on, because we have very different kind of physical structures, very different states, food habits are different, we have different genealogies, This is a population of 20 lakhs, 2 million, very, very uniform kind of pattern. So that's why. Sorry. So empirical antibiotics, you know this, Relationship, this is important. I want all of you to learn it. The relationship between mean corpuscular volume and red cell width. So I have started picking up. I pick up very easily. If MCV is low, RDW is high, is iron deficiency anemia. I just pick up see the report. Normally, if you don't know, you just go by, see the hemoglobin, see the TLC, because you don't know what is in the middle. So if MCV is low, red cell width is high, iron deficiency. If MCV is low, red cell width is normal, is thalassemia. MCV is high, RDW is high, is megaloblastic, folate deficiency. Simple blood report, and you see the indices, and you get a clue. Like yesterday I picked up, you have got iron deficiency anemia. The hemoglobin was borderline, 12 or 11. Still I said you have iron deficiency anemia. So this is important. This is one thing you should learn. MCV low, RDW high, iron deficiency. MCV low, RDW normal, thalassemia. MCV high, RDW high, megaloblastic anemia, folate deficiency, alcoholism. So this is what the basic, MCV average size is normally 80 to 100. Red cell width normal is 11.5 to 14.5%. MCV tells average size. RDW increases early in iron deficiency before MCV falls. It's a very important thing. If MCV is normal and RDW red cell width is still high, early iron deficiency. Normal RDW almost rules out iron deficiency. Somebody, patient comes to you and started eating bricks and stuff like that, you'll pick up, it's probably pica. Pica is abnormal eating, somebody is starting eating tuna of the wall. Pica, it's iron deficiency, especially in pregnant women, if they start eating all these things, it's pica. Correct the iron. Normal RDW almost rules out iron deficiency. So normal RDW rules out iron deficiency. Okay? A normal red cell width. Always correlate with peripheral smear, reticulocyte count, iron studies. How many of you heard of Takotsubo cardiomyopathy? It's a stress-induced cardiomyopathy or broken heart syndrome. It is transient heart condition characterized by sudden temporary weakening of left ventricle. Affects post-menopausal women. So if I've come across situations nowadays, it's been picked up in women more of unstable angina, prismatal angina, and I think in women the incidence of MI is going up. But then this is what sudden temporary weakness of left ventricle affects post-menopausal women, triggers are emotional and physical stress, results in excess catecholamines, named after Japanese octopus trap Takotsubo because of the apical ballooning shape of the left ventricle, mimics acute MI. So this is what you should know. Any post-menopausal mimics acute MI, normal coronary angiogram. So if somebody has absolute acute symptom of acute MI with normal coronary angiogram with symptoms of SOB, so this is what you should know, Takotsubo cardiomyopathy. Again I pressed that, sorry. Me calling my number after setting up a new ringtone in my mobile, just what happened with me once. So where's my phone? And some other ringtone. Rhabdomyolysis. A lot of you must be going to the gym. Those gym going, intense exercise at gym, severe muscle pain, Coca-Cola urine, very high CK, creatine kinase enzyme, due to breakdown of skeletal muscle fibers, leading to release of intracellular contents in bloodstream, leading to kidney failure. So, a lot of gym going people, if they have this, severe muscle pain. If they have severe muscle pain, immediately you should know. Coca-Cola urine, very high CK enzyme, and myoglobin CK potassium. Clinical features of this: muscle pain, weakness, swelling, dark coca. Anybody has a sore calf after intense exercise, start thinking, whether this thing. And in this situation, you should know the relationship between blood urea and creatinine. If urea is high and creatinine is normal, pre-renal, dehydration. If urea is high, creatinine is high, it's renal. If urea is normal and creatinine is high, is a muscle injury. So in this case, there will be high creatinine, okay? Don't pack too much. We're going, only staying for 2 days. That's what. Cirrhosis. Cirrhosis is not always reversible. Early stage cirrhosis can partly regress. Cirrhosis is essentially fibrosis. In a cirrhotic liver disease, is the liver palpable? The liver is not palpable, it's shrunken. We don't find a liver, shrunken liver. It's cirrhosis. Portal hypertension starts before symptoms. Clinically, silent phase exists. Platelet count is an early clue. The thrombocytopenia is portal hypertension. So that's an early clue in a cirrhotic liver setting. Due to splenic sequestration, AST-ALT ratio gives etiology. More than 2.1 suggests alcoholic liver disease, but values are usual. So any patient who has a history of alcoholism and you see thrombocytopenia, you immediately know that it's the earliest sign, earliest abnormality in a cirrhotic patient. Ascites is a turning point. Decompensated cirrhosis. Albumin reflex chronicity, I've told you before, not acute damage. If somebody's albumin is normal, I know liver synthesizing. It's a good prognostic marker. Liver is still preserved despite the damage to the liver alcoholism. Beta blockers do more than reduce blood pressure. INR is a better severity marker. Hepatic encephalopathy can occur with normal pneumonia. Now, how do you pick up hepatic encephalopathy in a cirrhotic liver disease? I hope it still remains it. I used to ask my patients, start getting 7 out of 100. Psychometric tests are the earliest that you pick up. I don't know if it's anything else has come, but the patients get confused, and 100 minus 7, he'll start fumbling. And then you immediately know he's going to do a liver coma. This psychometric test, So it's how you just ask him to do 100 minus 7, then 93 minus 7. So he can't. He'll fumble and immediately record it that he's going to early liver coma. Varices may bleed without warning. So pearls, cirrhosis is fibrosis, essentially fibrosis, nodules and portal hypertension, ascites is decompensation, low platelets an early sign of cirrhosis. Normal LFTs do not rule out cirrhosis. Now this is the last part of my session. I have to talk about memory techniques. This should be taught to all the medical students in the first year, So practice active recall. Instead of just rereading your notes or textbooks, actively quiz yourself on the material. Quiz yourself. Write the questions. Okay, let me find out the answer. This forces your brain to retrieve information, strengthening memory retention. So what I do is when I read something, I put that register as a memory register. I try and recall and write something. Maybe out of 10, I write 3 points. Then I read again. Again I write. Practice active recall. You are recalling because medicine is huge data. I was just telling you, the Park and Park has become this thick. My God, it was just half when we were there as undergrads, lot of data. Active recall, read and then write down what you remember. Again read, write down what you remember. You'll start retaining information. Use mnemonics. I always use mnemonics. Devices of memory aids that help you remember information through associations. So you know what mnemonics, APGGH, I know. By mnemonic, I know what are the causes of, say, motor neuropathy. Chunking. Break down large amounts of information to smaller, more manageable chunks. This can make it easier for your brain to process and remember. Create associations. Link new information to things you already know. The more connections you create, the easier it is to recall the information. These are all methods of memory, More ways for memory. Teach someone else. Maybe you teach yourself in the mirror. You read about alcohol, teach yourself, By teaching, you remember. Explaining concepts to someone else requires you to understand the material thoroughly because you're scared of teaching. Somebody can ask a question. Teach yourself. Teaching is a powerful way to reinforce your own memory. Get organized. Keep your study materials, notes, and schedules organized. A clear structure can help you retain information better. But teach someone else. Now I found, that's what in In my medical days, some people used to start teaching others. I used to not listen. It gave me stress because I missed out on that point. I used to not listen. I get scared. Oh, I don't remember it. But some people used to teach. Now I realize they used to teach others because they want to retrieve information. Remember, stay focused. Minimize distractions while studying or learning. Find a quiet place where you can concentrate fully on the material. In this regard, I can say that I'm not an early riser, but whenever I woke up at 4 a.m. and I studied at 5 a.m., I could focus more, but feel sleepy later. But I'm not this thing. But stay focused. Focus is better in the morning. Practice regularly. Consistent practice over time is crucial for memory retention. Review material periodically to reinforce your memory, which means, as I told you, if I read something today, I go and read again at 6 p.m. tomorrow. I'll have 60% retention of my facts, that way. 30 seconds rule. This is very similar to Feynman technique. Once you learn a new concept, stop and give you 30 seconds to write down an explanation with your own words. You've read something complicated. After 30 seconds, write down in your own words what you understood. You are making an attempt to remember. Maybe in your own words, it's very easy to remember facts. Imagine that you're explaining it to someone who never heard about it. By doing this, you will be using a principle called active recall, which actively stimulates your memory during the learning process. Look, it's okay if you don't stick with the 30 seconds. The idea is that you shouldn't overthink it. There are people with different kinds of memory. Some people have photographic memory. I remember there was guy in my class. We had history. I told him page number 35. He read the entire page. I was stunned. Photographic memory. He won't go on to what was page number 29. He'll read out the entire page 30 accurately. Amazing photographic memory, But then we have to apply our knowledge. It's just not cramming. We have to apply our medical knowledge on patients. So our memory is so important. So active recall. Right-handed versus left-handed. This way you will also realize your knowledge gaps. So you can get back to the material and understand it better. Then you can give you another 30 seconds and try to explain it better. Repeat the process until, so this was our previous slide only. 30 seconds, again you read, again you're writing 30, after 30 seconds write about it. You'll get better in memory, okay? So have a scribbling register, where scribble your memory, your facts, try to scribble, write, practice, you start remembering things, that way. Right-handed versus left-handed. Try playing the weaker hand when brushing your teeth, opening the door, dusting. This trains the side of the brain that is used less, the left side for right-handed people, and can thus improve memory in the long term. So try brush your teeth with the left hand. So that right brain area gets activated, so the kind of recall is better, left hand. Memory and mobile. Remove your phone from your sight. If not inside, it won't distract you. I think the biggest distraction is the mobile phone. We keep on seeing WhatsApp messages come or not. I'm sure there's a great distraction in reading. But once you get deep into knowledge, start remembering things. Wow, fascinating information. You get disinterested in the phone. You'll just focus on what learning you're getting out of that. You feel compelled, check it for 5 minutes after 25 minutes of work. Put it in the almirah. Ask somebody to hide you, that you don't know where you've hidden. Your colleague to hide you, but you can't locate it. After 25 minutes, you can check for 5 minutes. This way you will have an absolute win. Then the other thing is move your eyes from side to side. Moving your eyes from side to side for just 30 seconds, once a day, align the two parts of your brain and make your memory work more smoothly. Try this trick when you wake up in the morning. 30 seconds, both sides. Moving your eyes from side to side for 30 seconds. This will help align both sides of the brain and helping better memory. I learned a lot from my mistakes, so I decided to make the more mistakes to learn more. So never be afraid of making a mistake as an undergraduate, as a postgraduate. Once you're out of the market, if you make a mistake, your reputation is gone. You can make as many mistakes now. That is what learning is all about. There's a senior to guide you. Some senior resident or postgraduate will say, "Aise mat karo, don't do like this. Come here, I will tell you how to do a liver biopsy. I'll do a pleural tab." So, don't be afraid of making mistakes, but under guidance. I think, thank you. I think the fastest learners aren't the smartest, they're most humble. So always be humble in knowledge. I came across my medicine experience, few professors who had little knowledge, they were very arrogant on the rounds. So why you're not wearing a doctor's coat? Get out of the rounds. And the guys were humble, never cared for your doctor's coat. They were always ready to learn, And when I used to conduct the rounds, I used to always ask my residents, tell me anything else I've missed, anything else I've missed, anything else I've missed. Humble. Humility in learning is very important. No, anybody can teach you, even you can teach me. You can find out point, say, have you take this, there's a marker for this, TP, whatever, there's the new marker for Alzheimer's, for that matter. So, anybody can teach anything, humble. They ask more questions, they make more attempts, they're not afraid to look like beginners. Ego slows you down. I found the relationship of ego and knowledge. A person who has less knowledge is very egoistic. A person with more knowledge is very down to earth, like Dashrathi. He used to wear chappals and do endoscopies in the hospital. He was never care what he was wearing. What a knowledgeable guy. I mean, you Google him. He is working on sarcopenia, and he said one day that his boss told him that people like you and me win the Nobel Prize. So, humble, Ego slows you down. Curiosity makes you forward. Stay student always. Thank you. I think I'm at the end of the session. Thank you very much. Thank you. Thank you.
Thank you, Dr. Rajendra Kumar. That was a very insightful presentation on how you need to handle patients. I think he's gone over it system-wise, disease-wise. It will make us all the more wiser. I'm sure he'll be ready to, more than ready to take on questions from you all. Yeah, I think we can start with the interns, who are the primary targets today. Rakshita. Alan.
The whole effort that I have done is to sensitize you. That's the mic. The whole effort of my presentation is to sensitize you to knowledge, to be curious about things, keep reading. Now these days you have ChatGPT with you, Anything you see the patient, just try to remember, apply the knowledge, remember the clinical science, and be a learner always your life. You will keep learning all your life, because once you're learning, I remember, I was just telling somebody, when I was at AIMS Delhi and I was fourth year medicine student, there was a student from the London Medical School who came over. There was this child patient, I auscultated, and I said, as severe MS, mild MR, moderate TR, PVH, AF, NSR, and they were stunned. How did you diagnose it? I said, we are a poor country. We depend on our clinical skills. We don't, my patient cannot afford an echo. He can't afford to pay for an echo, which does in your country. They were like stunned over the clinical skills. And more so, whenever I had these kind of graduates coming down, I used to read, you should read extra, because that's the time that you kind of point them that you know your stuff. You know what you're talking about. And then you will get automatically respect by your peers, anybody visiting, because you added to the information they already had. You had, have you done this? Like there was this patient of primary, this hyperparathyroidism. I picked it up, the patient had tetany. I said, have you done this? Have you done this? They did not take me seriously initially. After that, started taking me seriously. I make sense. I talk sense. So if you are studying, if you're reading, if you're involved in this thing, then you may add to the information they already have, and they start respecting you. They take you apart. Yeah, boss, ek baar aap bhi dekh lo. Tell me if I missed anything. Which means they've already acknowledged you
as a terrific doctor. You know, they've already taken you seriously now. You know, they underestimated you, and I love when people underestimate me, because that is where I'll throw a challenge. And I'll cut them down to size. Don't mess up. You know, this is my input for you, you know. And then they'll automatically, what happens then when I'm in the hospital going around, they automatically start wishing me. And then the word spreads down entire picture, this guy is good. Then the orderly wishes you, the sister wishes you with this thing. Every hospital staff starts wishing you, because the undercurrent has gone, this guy knows. He corrects the diagnosis, picks up the diagnosis. So the whole idea of the session is that curiosity should be one thing, humility is another, and keep learning. The memory tricks is the thing that I've given, how to analyze data. And if you have understood to analyze data, you have done your job as a doctor, as far as my memory is concerned. Yeah. It's already 4. Very 4. So I don't know how many of you are going to States, but I think India is a better place, because here we have volumes and volumes of patients than the US. It's different that if I ever get a chance, I'll tell the seniors that we should be trained to publish in journals, international journals. We have enough patients. Viral hepatitis, America would see 100, we will see 2,000. We can easily do any study because we have a huge population. But those people know how to write. We don't know how to write and publish. Because when we publish, it gets published in an international journal. I have a very best friend, his Dean of SWIMS Tirupati, Dr. Aladi Mohan. If you know who he is, go and read Hutchison's. Open the few pages, he written a chapter in Hutchison's textbook of clinical medicine. That I mean, he's my best buddy, you know. But then the point is, he knows how to publish. When he was senior resident, he had about 100 papers in international journals. How many of us publish? We have enough data on tuberculosis. We can start picking up a finding. So there is no culture of publishing in this country. We should know how to analyze data, publish data, and for that paper to be accepted in an international journal, like the British Medical Journal, New England Journal of Medicine. You made your mark. So I think that is a very important area, you know. That's why if you're curious, you're picking up findings, you'll come across. Yeah.
Okay, if you have no questions, I think we will thank the speaker, Dr. Rajendra Prasad, in a traditional way, to please rise and acknowledge his wonderful talk that he did for us. Please request you all to please remain standing for the national anthem, please.